Thank you, everyone. Next, we will be starting soon with a panel discussion on universal health coverage. I request Dr. Ashok Kumar Bhardwaj to kindly come over the stage to kindly give a brief overview of the symposium. For panel discussion on universal health coverage, I request Dr. J.P. Narayan to kindly come over the stage. May I now request Dr. James Kingland from UK to kindly be on the stage, sir. I request Professor Dr. MSA Mansoor Ahmed from Bangladesh and Dr. Janaki from Colombo, Sri Lanka, Dr. Rajesh Guleria from Dharamshala, Himachal Pradesh, Dr. Suryodot Tripathi from Thailand, and Dr. Ajay Vatsayan from Australia to kindly come over the stage for the panel discussion. Thank you, dignitaries. May I now request Dr. Ashok Kumar Bhardwaj to give a brief overview about the Universal Health Coverage Symposium.
Good morning and welcome to the International Symposium on Universal Health Coverage, which is also the theme of the 46th Conference of Indian Association of Preventive and Social Medicine. I must apologize that the session was supposed to start at 10 o'clock in the morning, now got postponed to 11 for logistic reasons. Since 2015, when the concept of universal health coverage, or UHC, became a priority and as a part of sustainable development goals, all the countries are now striving hard to achieve the UHC in a very innovative and sustainable manner. And to discuss this very important and topical subject, we have this morning a panel of distinguished international and national speakers who will be sharing some of the exciting work they and their countries are doing. So first of all, keeping in the interest of time, I would like to invite Professor Ashok Bhardwaj, who actually needs no introduction. As a matter of fact, he is the chair of this international conference. Dr. Bhardwaj, please. I must also say that we have 90 minutes for this session, and we have 7 speakers. So, therefore, I would like to request all the speakers to make their presentations within 10 minutes so that we have some time at the end for discussion and question and answer session. Dr. Bhardwaj, please.
Thank you, sir. Good morning, everybody. So, universal health coverage, every delegate know everything about this, because this is the target which we are going to achieve under Sustainable Development Goal. But because it is a theme of our conference, so universal health coverage, igniting change and innovation in health. So I will just rush through the country scenario, how we reach this place. So this is the presentation of my parent. So globally, 400 million people, they lack one or the other type of access to one or other type of health services, every 100 million are pushed into poverty for accessing health services, and 30% of the global health expenditure is out of pocket. Then India's out-of-pocket expenditure is as large as 60, where globally it was 32, it is 67% in our country. So India is facing financial problem in health, providing healthcare. We are spending only 1% of the total expenditure globally, but we are contributing 60% of the population globally. So public expenditure on health is 1.2%. Only 70% of the population covered by some or other health schemes. So situation not uniform across the country. It varies from different state to different state. It is different in Kerala, it is different in Madhya Pradesh. So urban area have 4 times more health services per year. 35% poor household incurred catastrophic health expenditure. Then universal health coverage as a concept was born in 1883 when Germany introduced health coverage for achieving health status of its younger population. Later, in 2005, World Health Assembly adopted the term USC, and in 2010, World Health Report focused on health system financing for countries to build a platform for universal health care. Then, I will not go into the definition. What we do to be healthy, health worker, safe and effective care, medicine, who pay for it, policies, information, the people, services, products, finances, policy information, universal care for everyone. So this definition embodies 3 related objectives: equity in healthcare services, quality of health services, and financial risk protection. So this is how we are going to achieve it. Then why USC is important? For 3 reasons: health benefits, story of Brazil, I will not go in detail, economic benefits, Thailand, Dr. Surya will tell, and political, various examples. So in 1988, Brazil initiated an extensive program on health reforms and intention of increasing the coverage of effective services for the poor and otherwise vulnerable. Prior to 1988, just 30 million Brazilians had access to health services. Today, coverage is closer to 140 million. Then Thailand, I will not say. Then people say that we can have political benefit out of this also. USC is what USC, universal health coverage, is not. USC is not just health financing. It should cover all components of health system to be successful. It's not only about assuring a minimum package of health services, and USC does not mean free coverage. So evolution, Boer Committee 46, Mudaliar Committee, Jangalwala Committee, Kartar Singh Committee, Srivastava Committee, Rural Health Scheme, Health for All, National Health Policy, and National Population Policy 2000. Then evolution, National Health Policy 2002, NRHM 2005, NHM 2013, and National Health Policy 2017. So high-level expert group in India constituted in October 2010, and then they gave report in November 2011. So I will not go in all these details. This is how entitlement, national health packages, and choice of facilities. Then architecture, health financing and financial protection, health services norm, human resource for health, community participation and citizen engagement, access to medicine, vaccine and technology, management and institutional reforms. Backbone of a self-sustaining healthcare system. Then the per capita health expenditure of India is far less than that of Sri Lanka and China, and is around a third of that of Thailand. As a consequence, per capita out-of-pocket expenditure in the country has escalated to 67%. Recommendation, central government and state should increase public expenditure on health from the current level of 1.2% of GDP to at least 2.5% by the end of 12th plan, means that is already gone, and to at least 3% by GDP, which we have to achieve by 2022. So this is projected share, that ensure availability of free essential medicine, use general taxation as principal source of healthcare financing, do not levy sector-specific taxes for financing, do not levy fee of any kind for use of healthcare services under universal health coverage. Introduce specific purpose transfer to equalize the level of per capita public expenditure, accept flexible and differential norm for allocating finances, and expenditure on primary healthcare should count for at least 70% of healthcare expenditure, which is not there. Do not use insurance company or any other independent agent to purchase healthcare services. purchase of all healthcare services under the USA system should be undertaken directly by the center or the state government, and all government-funded insurance schemes should be integrated with urban healthcare system. All the health insurance card, the technical capability developed by Ministry of Labour and RSI should be transferred to Ministry of Health and Family Welfare. They are with the other ministries. So this I will not go. This I will not go. I will go to the last slide. Yes. So we have to provide our universal health care to each one in our country. I will say of India. And out-of-pocket expenditure, which is 67%, we have to bring it down drastically. So it is a teamwork. We can make a real difference to our social mission by teamwork, clear direction, and better performance. Thank you very much.
Thank you. Thank you very much, Dr. Bhardwaj. I think there are three key principles of UHC. One is access to comprehensive health care. Second is the quality, because access without quality is again quite meaningless. And third is the financial protection. And with that, I would like to invite the next speaker, Dr. James Kingsland. Dr. Kingsland is president of National Association of Primary Care in UK, and also international advisor on primary care, and also the faculty for disaster medicine in India and Nepal. He is a co-creator of a new care model in UK. I would request that he would explain as to how this primary care model in UK is being expanded as a part of National Health Service.
Chairman.
Dr. Kingsland. Yeah.
Many thanks and good morning, everybody. What a delight it is to be here. I've journeyed from Liverpool in the northwest of England. The journey was an interesting one, coming up the foothills of the Himalayas. I didn't have grey hair before we started the journey from Delhi, which was an interesting 9-hour jaunt with my friend and colleague who will be speaking with me this afternoon, Dr. Annapurna Sen. I'm going to just give an overview without formal presentation. If you can stand it, you'll be seeing me this afternoon when we'll be doing a more formal presentation in more detail. So I just wanted to give an overview. I'm still a family physician. I work in the northwest of England, not far from Liverpool, but also a professor of primary care at the University of Central Lancashire. And I do hope we can, with our experience, help the development of the primary care system, which is the cornerstone, in my opinion, of universal health care. And if we are going to create a system of universal health coverage, then primary care is vital. I also wanted to give an overview. Why is it so difficult? Why is it taking so long? And some of the hows that we might look to develop a system which can support promotive, preventative, curative, rehabilitative and palliative. And I would suggest that the primary care system is the only way we can do that. The declaration from Alma Ata, 40 years ago, we were saying about health for all, the health for all agenda. 40 years later, in October of last year, we had the declaration of Astana, again in Kazakhstan, which is focused from health for all to primary health care for all. And I think there's a worldwide recognition now, if we are going to achieve UHC, whilst we need our expertise in secondary and tertiary care, we need a comprehensive coverage of the 4 principles that underpin a primary care system. The point of first contact, which is local and accessible in a citizen's community. Holistic care, not disease-orientated, where it is person-centred rather than looking at the diabetic. It is the person who is living with diabetes. A comprehensive system for all common presentations so that we have the right level at which we deliver care. So most of the care needs in a population should be delivered in a community setting. And then finally, the coordination of care so that the citizen can move from their need based in the community to the appropriate time for hospital services, the more complex and, of course, high cost. So it's interesting to see the declaration of Astana saying that they are convinced that strengthening primary health care is the most inclusive, effective and efficient approach to enhance people's physical and mental health as well as social well-being, aspirations that is worldwide. So how can we do this? Because it often gets to very difficult political choices, and we'll be discussing a little bit more detail how the primary healthcare system is and can be further developed in India. But there's only one of three ways of doing it. We have been privileged since 1948, when the national health system was created for the UK, that it was based on the twin pillars of comprehensive care that is not based on anybody's ability to pay, free at the point of need. We struggle with that because it does require complete state funding, so we are privileged in the UK to not have any fee-paying system, or in general no fee-paying from the citizen who can access primary health care, hospital services, tertiary care services without the need to pay. But there has to be bold political choices. We are struggling to maintain that with the increasing demand on the system, new technologies, the demographic changes, the expectations of the public. We have a consultation rate in primary care of 8 at the moment. That means every single citizen in the UK visits their general physician, their generalist service 8 times a year. So that's getting to 400 million consultations just at that first contact, and trying to convert them to finished episodes of care. And we are struggling, which I think all health economies are going to be struggling with, the bold political choices. We've cut public spending as far as we can go. We've cut defence spending. There's some not enough investment in education, social care, police, prison services in order to invest more into health. Our politicians know if you go out into the community and say to our public, ask 100 people, do you want to put more money into healthcare? 100 people will say yes. Ask the same 100 people, would you like to pay more tax? 100 people say no. And we have this paradox that because our healthcare system and most healthcare systems where you're increasing the access without the ability of a person to pay is through the tax system. And we have the paradox of, and politicians know that the votes are always going to be on low tax rather than investment in public services. So there is the third way, without raising taxes, of utilisation of resources more efficiently and effectively. There is the sense that sometimes we may have enough money, we just don't make the right choices. And I would suggest that sometimes, and not to be critical, but I think there is an opportunity still with the investment that India is making to focus more on a community-based service than trying to get free access or freer healthcare in the tertiary sector, which we know can be very expensive compared to the primary care sector. Finally, just the issue that challenges us to deliver UHC is the workforce. And we know that the global workforce, by 2035, the global workforce may be 13 million health workers in deficit. 2035 is only 16 years off. That gives us 3 cycles of medical school training, maybe 5 cycles of nursing training. So there is a sense that we need to look at multi-professional and new ways of delivering care that makes vital use of the family physician, the doctor, the nursing, the paramedics and the wider recognised healthcare workers, but possibly, as we're looking now, other public service workers who can be trained in health interventions. I'll be talking a little bit more about this. So we are now looking on a call and check system from the postal service. Who visits people in their homes most days? The postie. The postal worker can assess whether somebody is in social isolation, at risk of health, at risk of crime. So we are having a structured process, and that's one of a number of ways that we can start on the integrated system and using our public services in a very different way. We are looking at the fire and rescue service, our fire officers who are doing falls prevention, who are looking at dementia care, smoking cessation, alcohol withdrawal. I asked one of our fire officers, why on earth would they be looking at health interventions? His answer was, Professor Kingsland, I've been hearing you talk about prevention. These are the people who set fire to their homes, people who fall, people who are drunk, people who are smoking. So we need to think differently when we have a global workforce problem. We want to get universal health coverage. We need to think about the most appropriate and what services we've got and utilising our precious established healthcare workforce to its optimum. At that point, Chairman, hopefully that's given some food for thought in why it's been so difficult, but why we must do it now, and some of the hows and some of the difficult decisions we're going to have to make. Thank you.
Thank you very much, Dr. Kingsland, for highlighting that the primary care principles are relevant, extremely relevant today, and also link between the primary health care, the UHC, and also health system strengthening. Unless and until we have a health system which is strengthened, there's no way that we can deliver primary health care. So with that, we move now to Bangladesh. I would like to introduce Professor Mansoor Ahmad. Dr. Ahmad is presently advisor to the Department of Non-Communicable Diseases in Bangladesh University of Health Sciences. He is also a member of International NCD Federation. And Professor Mansoor will bring the experience of Bangladesh in implementing UHC. Professor Ahmad, please.
Thank you, Mr. Chair, distinguished delegates on the dais, and ladies and gentlemen, welcome to my presentation. As already what is UHC and everything was explained by Professor Bardwaj, so I am not discussing anything what is UHC, but I'm expressing some of advances or activities that are taken and undergoing in Bangladesh. So a background of UHC of Bangladesh is catastrophic health expenditure for 5.7 million Bangladeshis into poverty. Inequity is present in most of health indicators across social, economic, and demographic parameters. And Bangladesh has made progress in health service delivery and reduced the burden of infectious diseases. Maternal mortality and under 5 deaths have been cut significantly in compared to the neighboring other countries of the Southeast Asia. And Bangladesh also moving forward towards achieving universal health coverage. The government has launched the UHC project on a pilot basis in 3 upazilas or sub-districts of Tangail district, which is a district in the northern part of Bangladesh. But the Director General of Health Services said with the SDGs focusing on the issues, Bangladesh is now looking forward to achieving the target by 2030, the end year of the global goals. And UHC has also become a central element in the adoption of SDGs, as good health underlies all aspects of the development, and this is reflected in goal number 3.8. What are the objectives? Equity, that is access to health service according to health needs, and quality of health services, efficient, effective, accessible, acceptable, equitable, and safe. Financial protection, which is the main focus of the UHC, and efficiency, ensure maximum health benefits are derived from scarce available resources. Steps taken for moving towards UHC are, because this time is very limited, so I am mentioning the highlights. The policy and strategic directions, National Health Policy 2011, Healthcare Financing Strategy 2012 to 2032, National Social Security Strategy in 2015, Quality Improvement Strategy in 2015. USC has overarching goal in next health sector program 2017-2021, and supply side expanded service delivery network. We have 13,000 community clinics, and there is a good number of new hospitals and beds, and increased health manpower, redesigning essential service package. The steps taken in Bangladesh towards USC demand side health protection scheme for the poor, SSK, that means the Swasthya Suraksha Karjakram, maternal voucher scheme, increase than the system strengthening by increased efficiency in procurement, distribution, and utilization of essential medicines and equipment, increased awareness, intersectoral coordination, and capacity development on USC, move towards generation of intelligence, evidence in policy development, and USC monitoring. The strategy is universal health coverage by 2032 and reduction of out-of-pocket expenditure by half, from 63 to 32%, and universal health coverage of total population by social health insurance, tax-based health service, community-based health insurance. Plan to cover almost entire population, poor about 48 million, formal sector 18.8 million, informal sector 85.7 million. And health nutrition programs, sector context, and steady progress in the sector and improving gain in public health, family planning, nutrition. There is remarkable progress in MDG 3, 4, and 5, an increase in skill delivery, then pilot freeze status and moving towards malaria elimination, and effective family planning program that is increasing, especially the CPR, improvement in health infra and outpatient indicators, infra and output indicators, girls' education, use of mobile and media networks, etc. There is some progress, and there is a good progress in life expectancy from 2000 to 2015. That is the life expectancy increased from 65 to 72, and the healthy life expectancy increased from 56 to 62. Challenges and service coverage of essential service to vulnerable, hard to reach, and urban population, strengthening the health system, improving quality of care, improving equity. And areas of challenges in Bangladesh, inadequate funding for the whole health system. Government budget is less than 1% of GDP. Total health expenditure is 3.5% of the GDP. And inequity in financing and utilization. Main source of financing for healthcare is out-of-pocket payment, 63% of the total health expenditure. Inefficient use of resources due to absence of proper resource allocation, utilization, and partly difficult financing process. Source of health financing in Bangladesh, major source of household out-of-pocket payment is 63%, and the voluntary payment 5.25%, government 23.909%, and rest of the world 8.35%. And catastrophic health expenditure, the incidence of catastrophic spending is higher among poor households in all years, and it showed an increased trend in the last 10 years. And expenditure for health comparison, I see Bangladesh is a per capita total health spending is very low. It's $27 is compared to other neighboring countries except Pakistan. Well, is the lowest, I think, among all the neighboring countries. And per capita government spending, where is also is very low, 9.7 US dollar, and is a little above Pakistan only, but the all other countries of the Southeast Asia are having more per capita government spending. And health budget over the years, the increase of the government budget as to the previous financial year is shown here, and we see that it's almost static, and 2016-17 fiscal year is 15.42%. And financial protection, progress and opportunities, building on country expenditure in providing financial coverage, then advocating for increasing domestic resources in health, and the improving capacity for fund utilization and tracking. There are some recent studies by the scientists, especially who are working for universal health coverage. And Bangladesh, some of the studies is I am showing finding of one study, which was a meta-analysis, and in that it's found that Bangladesh has comprehensive set of policies for UHC, that is a health financing strategy and a state recommendation for pooling of funds to create a national health insurance scheme and expand financial protection for health. Progress has been made in a number of areas, including the rollout of the essential package of health services for all, expansion of access to primary healthcare services, and the piloting of health insurance, which has been piloted in 3 sub-districts. Political commitment for these areas is strong. However, there are barriers pertaining to the larger policy level, which includes a rigid public financial structure dating from colonial era. And strengthening of UHC received a fresh momentum with the adoption of Sustainable Development Goal, the 8th target of the 3rd goal of which states achieve UHC, including financial risk protection, access to quality essential health care services, and access to safe, effective, quality, and affordable essential medicines and vaccines for all. Some recommendations are, number 1, to generate more resources for effective health services. We need to reprioritize health sector, which is within its national budget, to increase fiscal space for health towards achieving UHC. And number 2, improve quality and increase healthcare access, especially for poor and vulnerable. Need-based resources allocation formula to be recommended. Then operational plan should clearly indicate how much budget each operation plan will allocate to different tiers of facilities, especially at Upazila and below. MSR allocation to inpatient facilities should also include allocation for their outpatients. Number 3, enhance efficacy in resource allocation and utilization.
Professor
And
Mansoor,
conclusions.
Can you conclude now,
Yes.
please? Yeah.
The conclusions, we have good ground to take off, commitment from highest level, policies and strategic directions, undertaking and consequence for change, problems, and inadequacy of the existing system. Now we should systematically move towards UHC within rules, regulations, system coverage. Virtually, we don't have choice. we have to move fast. These are the references, and thank you very much for your patient hearing.
Thank you very much, Professor Mansoor. Once considered as one of the least developed countries, the Bangladesh has made remarkable progress in achieving many health indicators. And within the context of UHC also, he mentioned that over the last few years, the out-of-pocket expenditure has been slashed by 50%. So, but of course, there are some challenges also to be addressed. We now move to Dr. Janaki Vidana Pathirana from Sri Lanka. Dr. Janaki is National Program Consultant with STD/AIDS program in Colombo, Sri Lanka, with expertise in behavior change communication. She'll talk about how Sri Lanka is making progress towards HC by investing in primary health care. Dr. Janaki, please.
Good morning. Respected Chair, panel of speakers, distinguished delegates. First of all, I would like to thank organizers for giving me this opportunity to share our experience. So I am going to talk about achievements and way forward for universal health coverage in Sri Lanka. So I am going to talk about population coverage, service coverage, and financial protection. So before that, I will give a brief overview about the health system in Sri Lanka. Sri Lanka provides free of charge health services for all in public health sector. Sri Lanka is one of the few countries in the world giving this free of charge health services. This free of charge health system is funded by government tax revenues and managed by Ministry of Health and its provincial counterparts. We have a very well-established preventive and curative care networks. We have achieved many health achievements. So already Sri Lanka has eliminated malaria, polio, rubella, and filaria. And also we are going to submit the elimination certificate for WHO in relevant to prevention of mother-to-child HIV and syphilis in this month. And we have very low maternal mortality and infant mortality rates compared to the other Southeast Asian countries. And we have high vaccine coverage for vaccine-preventable diseases. And also, the present target is to end new HIV infection and new tuberculosis infection by 2025. So when we talk about the service coverage, we have a very good satisfactory health accessibility in public health sector throughout the country, and almost one doctor and 2 nurses for 1,000 population. 50% of outpatient care and 90% of inpatient care is provided by the public sector. Government directly procure majority of pharmaceuticals and rest is by the private sector. We have high service coverage for all over the country in relevant to MCH services. We provide domiciliary care at doorstep through public health midwives. And when compared to the MCH, coverage for non-communicable diseases, youth and adolescent, and elderly care are lagging behind. Bypassing of health system, healthcare services are common due to non-structured referral system. There is a separate referral system, but it is not structured. Anybody can bypass the primary healthcare system. Maldistribution of specialties can be seen in some areas. Private sector charges are relatively cheaper as they need to compete with the free health services in the public sector. Private sector provides the choice of doctor and the convenient time for the patient compared to the public sector. public sector does not provide that. Government doctors are allowed to work in the private sector out of their duty times. When we talk about the health financing, few health financing reforms were undertaken in the country. In future, it is essential to reform new health financing system. Overall, 90% of total expenditure is sourced by government budget. Government spending as a share of GPD is 1.6% and is lower among Asian countries which have similar income level. Low government revenues are the main reason for Sri Lanka's relatively low level of health spending. It accounts about 40% of total health expenditure. It is about average for income level and used by better off than poor people. Financial risk protection is quite good. Most of our out-of-pocket expenditure is incurred by the rich people. Poorest spends less than 2.5% of their household income on health. Only 0.4% of Sri Lankans leads to poverty due to health expenditure in 2015. These are future recommendations. We need strong primary health care system for non-communicable diseases, youth and elderly, and further strengthening of MCH system. We have a lot of policies, laws, policies, programs, and strategies relevant to a lot of health areas, but there is room for improvement too. We need to have a proper structured referral system to avoid bypassing the primary health care system. Currently, under the World Bank Fund, countries reforming structure in the primary health care system, especially for non-communicable diseases. Needs to increase health budget. The last year, total budget out of the government total budget was 4%. Also, it is important to address understaffing and shortage of specialties. It is important to recommend proper health information system. Last month, it has been established. It is important to structure throughout the country. Efficient system to shorten the procurement cycle for drugs, especially in government sector. It takes long time to procure due to government rules and regulations. Thank you, but I want to give a special announcement. You can see this poster. Actually, it's not, people can't see it. Right. So this is the first Southeast Asia Regional Group Meeting and International Epidemiological Association with the 24th Annual Academic Sessions of the College of Community Physicians of Sri Lanka. We are going to have it in September 19th to 21st in Colombo in Cinnamon Rand Hotel. So theme for the conference is Smart Investment for Universal Health Coverage. I kindly request you to attend the conference. There are many speakers, many plenary sessions, oral presentation, poster presentation, and symposiums are there. So now abstracts have been opened. The closing date of abstracts is 4th of April. I kindly request you to share your evidence with in this international forum. Thank you very much. See you in Colombo. Thank you.
Okay, thank you very much. Is it in 2021 or 20? This year. I thought you said 2021. Thank you very much, Dr. Janaki, for your presentation. I think the health financing coming as a running theme as we are discussing about UHC. I think that is applicable to most of the countries. I should also inform that Over the past 5 to 6 years, Sri Lanka has already achieved elimination of malaria and also lymphatic filariasis. Now you are moving to elimination of mother-to-child transmission of HIV. So quite a... No. That is by 2025. That is a universal goal. Okay, thank you very much. We move next speaker, Dr. Suryadev Tripathi from Thailand. Dr. Tripathi is Director of Moral Promotion Center in Bangkok, Thailand, and also he informed me that he is also going to be the Director of Mental Health Department in the Ministry of Public Health. And as all of you know, that Thailand is one of the few countries which have already achieved universal health coverage. So it'll be very interesting to hear from Dr. Tripathi as to how Thailand achieved universal health coverage. Dr. Suryadev, floor is yours.
Thank you so much. And I'm also very delighted. It is my first time in Shimla. Actually, that is very fantastic place, and also have a very first experience in Shimla, also in Chandigarh. First of all, I would like to thank you for IAPSM conference in 2019 right now, and also Ministry of Public Health of Thailand. The topic that I would like to present to you is Thailand universal health coverage, health system development. I try to summarize in this slide as the whole. If you look at the Thailand at a glance, actually we have also very good luck news about the new ranking about the health system development announced by WHO. We also become the 7th rank of the world. Thank you so much. Thank you. Thailand at a glance, population, we have population 68 millions. And if we comparing about the GNI per capita is 5,410, we becomes upper middle income country. And health status is life expectancy is 77 years for female and 71 years for male. Under 5-year mortality rate is right now is 12.6 per 1,000 live birth, and maternal mortality is 26 per 100,000 live birth. Skilled birth attendance is nearly 100%. And universal health coverage is also beginning in 2002, financed by tax, almost zero co-payment. I mean, all of you ever heard about 30 baht? It is a Thai currency. 30 baht is equal to $1. That means even you have some kind of liver transplant, heart transplant, the people, poor people could pay only 30 bahts. Zero co-payment, nearly zero. Total health expenditure is 4.6 of GDP, and it is also be $264 per capita, mainly by public sources, nearly 80%. And we still have also out of pocket around 11% of THE. If compared with the general government health expenditure equal to nearly 20% of GGE. GGE is meaning general government expenditure total. I would like to example one of indicators such as under 5-year mortality, how we can declining the trend, and what health system in Thailand developed try to coverage the whole people in Thailand. This is one of the indicator we talk about the under 5-year mortality rate. If you look at the graph, we are below than upper middle income countries. We are on par to the high income country non-OECD, just only above from the high income OECD. It is also be equal to 12% per thousand live birth. And here is the historical of the development of health system and financial protection. I will use the one of the indicator that is under 5-year mortality rate per 1,000 live birth what is going on time to time for health system, try to coverage all the people in Thailand, such as if you look at the 1970 to 1975, Ministry of Public Health also announced about every medical degree they have to mandatory to rural service, at least for 3 years. I mean, new generation, they have mandatory to rural services. And also set up the whole nation of the nursing college. And 1925 to 1980, also scaling up the district hospital, village health volunteer, the whole nation, and also national EPI program. Parallel together with, you look at the green color, that is also in 1925, we have a low income card scheme. Try to coverage about the people that is very poor. And in 1980, we have also civil servant medical benefits scheme too. In 1983, voluntary health card before running to the social health insurance in 1991. And even we also facing about the crisis, Asian economic crisis, according to the oil crisis, if we remember about that in 1997. But 5 years later, we also have achieved to announce about the universal health coverage in 2002. This is also one try to comparing about the long march toward universal health coverage since 1975 to 2002. If you look at the beginning in 1975, GNI of Thailand is only $380 US. And we have also have one of the public scheme, medical welfare scheme, and try to coverage about the population, 30% of them. And in 1980, civil servant medical benefit also be announced, this kind of scheme, and try to coverage about the 40% of population. After that, in 1983, voluntary health card coverage about the more than 50% of the population. And in 1990, you will see that we have also social health insurance who work in the private part and also working in the labor part. There also we have those kind of social health insurance announced in 1990. This also we coverage about 70% of total population of Thailand. We still have 30% of uninsured. That is why we also have tried to build up this kind of USC, universal health coverage, that we achieved in 2002, coverage 100%. This graph we show about that USC can be started at achieved at low to middle income level if you have effectiveness and try to manage very well. So Thailand right now have 3 main public schemes. If you look at each of row, that is the first row show about the civil servant medical benefit scheme, that registration by royal decree in 1980, and coverage about the 6 million population. Source of finance is tax funded, and payment method is fee for service and DRG. Organization management is Comptroller General Department and Ministry of Finance. The second scheme, Thailand public scheme, is social health insurance. It is an act in 1990, coverage about the 11 million population. Source of finance is tri-party. It's also being funded by private sector and also from the labor and also from the government. This tri-party, close-ended budget, and payment method is capitation and DRG. Organization management is Social Security Office and Ministry of Labor. For the universal health coverage is an act in 2002. 75% of population coverage and 51 million population. Source of finance is tax funded, close-ended budget. Payment method is again capitation, global budget, and DRG and fee schedule. Organization management is National Health Security Office. It is a public organization. If you look at mostly of our public health department is very well developed. They usually make service for 75%, only 25% health facility in private sector part. Here is the graph time to time. And if you look at the bottom, that is a lot of government change, but continue political commitment to universal health coverage since 2002 at the beginning to 2000, actually right now and go beyond. I mean, if you look at the beginning, it is a Thai currency. At the beginning, we invest about 1,200 baht. It is a Thai currency at the beginning, and right now it's 3,000, around 3,000. Why it is increased? If you look at the chronology of the benefit package extension in the universal health coverage, at the beginning, the coverage is outpatient, inpatient service, and high-cost care, and also accident and emergency. But if you look at the chronology, especially in the 2008, even Thai traditional medicine, renal replacement therapy, such as peritoneal dialysis, and also including about the kidney transplant, including all of related medicine, voluntary methadone replacement, and many things else here. And also, if you look at in the 2010, is also be psychiatric patient, inpatient without limits on the long length of hospital day. In 2012, that is more package, packaging about the liver transplant for hepatic failure in patients younger than 18 years old, and heart transplantation. And also right now in 2016, long-term home and community care for frail elderly people, and home-based and community-based for psychiatric care. So USC scheme, clear expectation, extend coverage to all, and universal benefit package with emphasis on primary care, decrease out-of-pocket payment. And we also try to harmonize with UC scheme with other government finance insurance, such as social health insurance, also civil servant medical benefit. And we have also Thai health promotion that is also in the protection, promotion, prevention system. Here is the graph we show about how huge increase in access to primary care. If you look at the 1977, it is a reverse triangle. Green color is primary care. It is only, at that time, it's only 30% services in rural health, while red color is district hospital. And majority at that time is they make services in general hospital. But if you look at the bottom, that is become upright triangle, and broadening about the green color, that is primary rural health center be developed, and also be a more coverage. In 2010, more than 50% they use in rural health center. Evolution of rural health system in Thailand, basic rural health extensive started in late 70 to early 90, which are 100% coverage of hospital in all the rural district area, 100% coverage in health center in all rural community, and we call about the health promotion hospital. Rapid increase of human resource of health training, such as doctor, nurse, voluntary health volunteers, through the rural recruitment, local training, hometown placement, and compulsory public work for graduates with adequate motivation and incentive. This motivation was achieved through a decision to freeze capital investment in urban hospital for 5 years, since 1982 to 1986, and shift the budget to build up the rural facilities. It was decided during the military government under the strong primary health care and health for all and poverty eradication policy. Here is the picture that we show about the district health system hub for poor outcomes. It also be published in the Lancet in 2013. The primary health care we coverage about health promotion, disease control, health care, rehabilitation, consumer protection, and we don't, working by alone. We have right now, we have also district health board that is also working as a community network. The rural health facility also working with the spiritual leaders such as temple, school, local authority, private sector, community. We working as a together. That side, you also see the picture of the rural health center with 3 to 6 nurses and paramedics cover the 2,000 and 5,000 population in their area. And rural community hospital with 2 to 8 doctors cover 30 to 80,000 population. So GC scheme achievement in Thailand, poor utilization and benefit incidents, which all this kind of thing is we already published in the journal. Significant reduction of out-of-pocket payment and low level of catastrophic health expenditure and impoverishment, and low level of unmet health care need, and on par with OECD average. Steady decline in all-cause mortality between 2001 and 2014, reduction in the inequality of adult mortality across the geographic area. This is the important note, and that's why I has also symbol with on my suit here. The success of universal health coverage in Thailand doesn't depend only increasing health budget, but also or more on dedicated spirit of qualified health professional who took the motto of the Prince Mahidol seriously. Prince Mahidol is our King Rama IX father. That motto is true success is not in learning, but it is in application to benefit of mankind. And money, if you look at the money, if not well managed, may create conflict and troubles too. Thank you so much. Sawasdee krap.
Thank you. Thank you very much, Dr. Surya Dev.
I have one short
Yes.
video. I have time? 2
Video?
or 3 minutes? Video.
2-3 minutes. 2-3 minutes, okay, I think.
Yeah, please. Go ahead.
This is the theme of the conference, so I think even if we spend a little bit more time, it's worthwhile. Give women time. Women's Thank you. Thank you very much for the video also. I had the privilege yesterday of chairing a panel discussion where all the 5 speakers were women. This was on emerging infections, including zoonosis. And thank you for highlighting the critical importance of health workforce and also political commitment, primary health care, including health promotion. I think these are some of the critically important areas. In Thailand, I remember also the Prime Minister used to chair the National AIDS Committee. And HIV/AIDS was part of 5-year development plan of each ministry. And they have the budget also. So these are some of the areas I think shows why political commitment for health makes such a big difference. Thank you. So we now move from Thailand to Australia. I'd like to invite Dr. Ajay Vatsyan. And Dr. Vatsyan is obstetrician gynecologist and senior specialist based in New South Wales in Australia, helping to improve health outcomes of women. So Dr. Vatsyan, sorry?
Can I have my
Okay, he is also alumni of IGMC here in Shimla.
Thank you.
Welcome, Ajay, and floor is yours.
Thank you. It's a pleasure to be, I would like call back home. This is my first home, and the second home is Australia. And I work in Sydney. Mr. Chair and distinguished guests, I present the opposite spectrum of UHC. What we have seen is presentations which are from different panelists where targets are still to be achieved. People have achieved targets like in Thailand and in Australia. Just as a statistic, Australia ranks second in UHC coverage in the world, especially in the OECD countries. So where I come from, I'd like to share with you what works and what is still not working. As we all have heard from different speakers, what is exactly universal health coverage? Basically, the population needs access to essential and quality services, and they should not be spending a lot of money on the health. And there are social determinants which decide these things: the conditions of individuals' life, their location, where they're placed, their age, and the environment. And the effect of these SDH factors compromises both health and the healthcare system. Just an introduction of how we see UHC, or universal health coverage, in Australia. It's a lovely view of the Sydney Harbour. I thought I'd lighten up the situation a bit. Now, Australian health system actually has got a mixed public and private healthcare system. And by an act of parliament, which is named as the Health Insurance Act 1973, this mandates affordable healthcare to all Australians. Way back, an act of parliament ensures it. And the fact that there's private sector involvement in healthcare, it ensures individual choice. So people who can afford buy insurance, and the government gives them incentives. So there is a 30% rebate on your tax if you have private health insurance. This sort of decongests the public health system, and a lot of people access good quality private health services. Though the public health services, or which is known as the similar counterpart in India would be the government hospitals, are equally good in terms of facilities and infrastructure. Who are responsible for looking after the UHC, or the universal healthcare? The federal, which is the central government, state, territory, and local governments. They are the funders, they develop the policies, they regulate it, and they ensure service delivery. Commonwealth, or the central government as it is called here, it is responsible for funding Medicare, the pharmaceutical benefit scheme, the national immunization programs, subsidies for aged care, and private health insurance rebates, which I mentioned earlier. The state governments, in turn, manage public hospitals, or the government hospitals, so-called government hospitals. They fund community and mental health services, and they also look after the ambulance and emergency services, which are the patient transport schemes. And then finally, in the previous talk, we were talking about convergence. There is convergence of two arms of government here, the federal and the state. They both look after the funding for public hospitals and palliative care. And finally, the local governments, which are the municipal councils, or which are similar to what we have in, say, Shimla. They look after the environment health services, which primarily means sanitation, and then community-based health and home services. Now, I think so the flagship of universal healthcare in Australia is Medicare Benefit Schedule, or the MBS. What this does is, all citizens have a Medicare card. It's a simple card. It universally subsidizes payments for all hospital and medical services. Now, how does the government fund this Medicare system or the Medicare benefit services? Interestingly, Australia has a population of 24 million. All 24 million, at least the people who are working, pay tax. Everybody is in the tax net. So there's no way out of the tax net. And then, everyone who pays tax, a certain amount of dollars or certain amount of money is deducted from your pre-tax income. So for people who get a high income, 2% of their salary is deducted before it is disbursed, and it goes into this big kitty of the Medicare health system. For people who earn less or below a certain threshold, they lose about 1.5 to 2% of their income. Now, income from this levy, which goes to a central pool, a central kitty, which is shared by the central government and the state government, it ensures free treatment for public patients in all public hospitals. And even if a private patient who holds a private insurance comes to the public hospital, they take their Medicare card to a Medicare center after they've had treatment, and they are reimbursed 75% of the fee of that particular treatment. And say if they go outside, they go to private health or private health coverage providers, say private hospitals, Medicare covers 100% of the mandated fee. Say to see a GP, the fee is say $37. They go to see a GP in a private hospital, they get $37 back. Now, it is the choice of the GP who's sitting in that private hospital to charge extra, which is called out-of-pocket expenses, which are then paid by the patients. And if they come and see a specialist like me, they get 85% of the fee which I charge for a consultation. And the second flagship program which looks after universal health care is the pharmaceutical benefit scheme. What this ensures is all patients get subsidized payments for prescription medicines. It is universal, whether you have private insurance or not. As long as you have a Medicare card, you're entitled to subsidized payments for prescription medicines. And then there are two varieties of patients which are identified. One is general and concessional. So a general patient, say like me, I need a medication, I go to a pharmacy, I pay a standard co-payment, which is standard for anybody, irrespective of their income. So doctor will pay the same amount, say for an inhaler for Ventolin, everybody pays $40, whether I'm a millionaire or I earn $2,000 a month. Everybody pays the same amount. The remaining amount for Ventolin inhaler is subsidized by the central and the federal governments. I hope that gives you an idea how the system works. Then, this particular payment system is actually indexed with the CPI, or the Consumer Price Index. So it is basically, in simple words, indexed with inflation. With every year, they'll keep adding more benefits so that people can get more money or can save more money out of their standard medications. In addition, they have something which is also called the safety net. So say a person has got multiple chronic illnesses and they purchase a significant amount of medication throughout the year. The safety net will pay for medicines worth $1,521 for the whole year at a concessional rate. So they don't have to pay a lot through their pocket. And once they have crossed this threshold, they go into the second category, which is called the concessional category. The people who are in the concession category only pay $384 a year. After that, every medicine they buy from the shops is free, once they have reached their threshold. So where does Australia stand in terms of health expenditure? I was surprised to see the different percentages of GDP which most developing countries are spending on their on health. I mean, they're in single digits, 1.2, 1.3, 1.6%. The Australian government spends 10.3% of its GDP on universal health care. And that is the crux, as the chair pointed out. that funding is very important. Commonwealth Health Funding, the program is second out of 11 high-income countries, and the health systems are measured against the care process access. It has been found to be number one in administrative efficiency and healthcare outcomes. But then we have barriers as well. I'll quickly go through the barriers. As we all know, or you would know, we have Aboriginal population, which translates into, say, tribal communities in India or other countries. We have problems with them. Their outcomes, their life expectancy is 20 years less as compared to the Caucasian or the white population. And the reason are they have got cultural barriers, remote and rural conditions. There's overall socioeconomic disadvantage. And the reason for cultural barriers are the concept of sexuality is very different from what we teach. They don't believe in contraception, or the contraception doesn't exist. And there is a different understanding of health in their mind, because most of them are nomads. They don't stay at one simple place. And they feel that the healthcare has got a bias against them. And more significantly, they feel racial prejudice, because they were the original inhabitants of the land. They were replaced by a white community. And then there are immigrants like me who have moved there. So suddenly they feel marginalized slowly and slowly, like any and every tribal community all over the world. So what this does is they alienates them from the mainstream, and they suffer from poor health outcomes. And the second barrier is the ratio of nurses in the rural areas is half that of metropolitan areas. So care is significantly affected. And there are, I'll just finish quickly now. We still have issues. What has happened is, because the government wanted to channel the funding which was going into Medicare to other areas like National Disability Insurance Scheme, etc., they put a freeze on the amount of concessions people will get through Medicare system. And it has been frozen since 2013. And because of that, in 2017, 12% of Australians did not go to a GP or a specialist, because they had to pay out-of-pocket money, and they can't afford it or they don't want to pay, which has led to a rise in poor outcomes. And then there's a significant strain on tertiary centers and secondary healthcare centers. So we are dealing with some issues which should hopefully improve over time, and there's scope for improvement.
Dr. Ajay, can you please?
Thank you.
Yeah.
And that is the future. Thank you very much. Thank you for your time.
Thank you. Thank you very much. Thank you. We now have the last speaker for the session, Dr. Rajesh Guleri, who is the District Health Officer in Kangra district of Himachal Pradesh, based in Dharamsala. He is the architect of Ayushman Bharat implementation in Himachal Pradesh. Yeah. Dr. Guleri, please.
Thank you, Chair. Distinguished panelists, ladies and gentlemen, I am indeed privileged to be amongst you to present before you the perspective of the host state, Himachal Pradesh, in context of universal health coverage. Although I don't have a structured presentation, but I'll just like to discuss a few operational aspects and implementation in the field. How was it done and what we aspire for. Himachal, in spite of having challenges of difficult geographical terrain, has best health indices in India. As is true for the nation, there are disparities in the healthcare delivery system in the states, but Himachal still has some advantages. We have for a 7 million population, we have very good penetration of health system and public health system in the state, with about 2,200 odd the health sub-centers, 500 PHCs, and 6 medical colleges. And at times we feel that that is more than what we require for such a small state. Even the HR position is not bad as compared to the other neighboring state or states with similar geographical terrain. We just need to repool and place them well so that actual utilization is improved. Universal health coverage in India is still at the incipient stage, and it's more of a concept. So whenever we talk about universal health coverage, we primarily see how can we give a health insurance model coverage to people and not thinking about the primary, preventive, promotive health care. In Himachal, we have slightly had a better vision than although it may appear a bold statement, but still we have tried to do few things at the government level, because 80% of the healthcare seeking behavior is dependent on the public health care system in the state. So if we are talking about health insurance coverages, Ayushman Bharat, the Pradhan Mantri Jan Arogya Yojana, the health insurance scheme of Government of India, which is being implemented across the nation, covers defined population with some socio-economic factors. And it gives coverage of about 5 lakh rupees in a year to the family for getting treatment for indoor conditions, more than 1,800 conditions, free of cost at those empaneled hospitals. And the hospital gets reimbursement from the scheme itself. The packages are good now, and more hospitals are willing to get themselves empaneled. In Himachal, for a small state, we have 200 hospitals empaneled to provide services under the scheme, and 50 are from the private sector, and which are very good hospitals. But it covers 50% of the population, because there is a criteria for defining population. In Himachal, same coverage was given to the other people also. 50% are covered under the Ayushman Bharat. 25% are either government employees or pensioners or dependents of them. So they are covered under the government reimbursement scheme. Rest of the 25% have been offered another scheme, which is a self-financing model and is a sustainable model. So other 25%, irrespective of the income or social position, they are being offered the same package which the government Ayushman coverage is offering you on the payment of a notional premium. So in fact, Himachal probably is the only state in India which is offering health insurance coverage to 100% of its population on nominal premium, which is very nominal. It is either zero premium for below poverty. It is some 365 rupees for few categories, which are either 70 years or above, more than 40% disabled, single women, and some few other categories, and 1,000 rupees for a family floater for all other categories beyond the earnings of the family. And this becomes relevant because the recent data of Himachal Pradesh suggested that although speakers before me have talked about percentage GDP spending on health, 10%, 7%, 8%. In India, we are struggling at 1.1%. Himachal is slightly better. We spend, after this recent budget allocations, we spend about 2.6% of our GDP on health, which is amongst the best in the country. And we aspire that we achieve a level of about 4% by 2020. But at the same time, it's very pertinent to mention that the out-of-pocket expenditure in Himachal are also one of the highest in the country. So average family income in Himachal is 5 lakh rupees, and government spending on health is 10,000 rupees. In addition, out-of-pocket is 15,000 for a family. So it is 25,000 for a family, the expenditure on health, which is 5% of the total income a family is getting. So in view of this, we needed a scheme which covers the entire population. And in line of that, which is the line of universal health coverage also, we have this HIMCare. HIMCare covers, or Ayushman Bharat covers only the indoor admissions. And at times you have catastrophic expenditure on health due to OP conditions or other conditions also. For that also, we have a scheme called Mukhya Mantri Chikitsa Rahat Kosh, wherein on the recommendations of the district collector or the chief minister, the reimbursement for any catastrophic expenditures is also done. So to summarize, the three pillars of UHC talk about equality, quality, and affordability. So we are working towards all three of them. Equality or equity, we have difficult geographical terrain. There are snowbound areas. We tried doing some things. We tried doing telemedicine. We have tried to give more incentives to specialists so that those vulnerable populations are also have access to those good quality services. For ensuring quality, we have now inter-academic medical council of medical colleges also. We have started DNB courses also. And for affordability, for decreasing the out-of-pocket expenditure in OP outdoor, there is a recent scheme with the name of Mukhyamantri Nishulk Dawai Yojana, wherein 330 medicines in medical colleges and district hospitals are being provided free of cost, 216 in the civil hospitals and 106, and that is as per the essential drug list identified by the state. So this is the experience and implementation strategies which we had in Himachal. Although I once again reiterate that whatever we are trying to do may not match with the international achievements, but still I feel there is a vision and there is a direction in which we are trying to head. Thank you so much, Dr. Lidis.
Okay, thank you. Thank you very much, Dr. Rajesh Guleri. I consider Ayushman Bharat as a huge and unprecedented opportunity, not only to provide secondary and tertiary care, but an opportunity to strengthen primary care by transforming sub-centers and primary health centers in India. So this kind of opportunity, I think, never available before. From that point of view, I feel that this scheme can prove to be a game changer in the future, as far as India is concerned. So with that, I think we can have 10 minutes for discussion, question answer from the floor. Is that okay?
5 minutes.
Yeah, because all the international, all the distinguished speakers from different countries are here with wide variety of experiences. Let's open for discussion. Kindly use the mic and identify yourself and indicate as to who the question is for. Any comments? Can you go to the mic, please? I think it's, there are two mics. Yeah, okay, you got a mic. Okay. Yeah.
Yeah. I'm Kamlesh Jain from Chhattisgarh. I'm working in health sector from for last 14 years. I recently attended the workshop.
What is the question?
Health.
Please straight away go to the
Actually,
question.
just varieties of the model we heard through Australia, even Thailand and Sri Lanka, and other part of the country, even Shimla. Bangladesh also, sir. But we are little bit confused. What is the role of public sector, public health facilities, and role of the private sector? Some of the countries are totally dependent on the public health facilities, like Sri Lanka and Thailand. They are working on the model where the public health facilities are working. But the Australia, they are saying that yes, they have a private sectors and private sectors are also working for UHSC. Shimla just shared with Himachal Pradesh ki they have covered all the populations with low cost premiums and other things, but they have a high pocket of out-of-pocket expenditure model. Means they have a high pocket of expenditures. So in these type of varieties of throw, we are a little bit confused. So now I want to know something on private sectors. What is the role of private sector in UHSC? Because Ayushman Bharat is promoting
Okay,
promoting private
please.
sector.
I think we don't have much time,
Thank
you know.
you.
I think a discussion like that will take a lot of time. Maybe Dr. Kingsland, would you, UK is one example where the GPs are playing a critically important role in providing primary care. And Australia, at the same time, we need to look at what infrastructure you have. Try to strengthen the, you know, whether it is government sector or in the private sector. Yeah, you may like to.
Yes, thank you. And probably that's an oversight because there is a private sector and a flourishing private sector within the National Health Service in the UK. What we want to do, what's always been planned for the citizens is that they have a choice. The universal healthcare we have, which is free at the point of need, not based on anybody's ability to pay, doesn't mean to say people don't have choice for seeing a consultant in the private sector through either an insurance base. About 10% of the population of UK still take out healthcare insurance because they choose to go to the private sector, so we'll have private hospitals. Not a lot of private service in primary care, or can personally pay as well. So we still have insurance-based systems, but the underlying principle is that you do not need to pay if you want to use the public sector. But it doesn't mean to say there isn't quite a flourishing private sector for those who choose to pay, but that is often then skewed towards those who can afford to pay. Does that help?
Can I add a comment here, James? I think we know the system with the NHS is struggling as a model of care. And NHS's primary focus initially was universal healthcare free, but people had to access, say, through GPs or through hospital. It was hospital-based care. And that's where I think there has to be a bit of dichotomy, a greater movement towards offering people incentive to take private health insurance, but in a way where they can be subsidized, that private health insurance is subsidized by the federal government, which decreases the load on the NHS. I think that would be my comment. And to the doctor from Chhattisgarh, this is something which we have seen. I would say it works in Australia, where there is a mix of private and public sector engagement in UHC or universal health care. What the government has done is, for people who even take out private health insurance, say if it's a sales girl or a sales boy in a department store, they take out private health insurance and they pay the premium every month, they get 30% rebate on their income tax. So people are actually encouraged to take out insurance and they get a rebate. So basically, say if the insurance is $300 a year or a month, the central government or the federal government will pay $100 or $150 of that insurance. So that decreases the load on the public healthcare system.
Okay.
It leaves more resources for the public health to use, and private gets what they want. They earn money.
Okay, I think in India also a lot of private hospitals have been impaneled to provide secondary and tertiary care within the Ayushman Bharat scheme or PMJ.
Little clarification from our side.
Comment.
Increasing out-of-pocket expenditure led to the policy change. And then we introduced this universal coverage model. So we don't have figures after launching this schemes. This is a very recent initiative. So we hope that OOPs go down after this.
The out-of-pocket expenditure as a result of social insurance have come down. I think Thailand is within a span of 15 years, I think out-of-pocket expenditure came down from 42% to now about 12%. And as of 2011 data, I think even now maybe less. So,
Sir, can I ask just one?
Yeah, you have one more question. Yeah, please.
What is the role of medical colleges in universal health coverage? It happens many times that when the services are not available at a rural hospital or district hospital, the patient is referred to government medical college hospitals. And there, the situation regarding the manpower, infrastructure and facilities at many of the government colleges is not satisfactory. So we have to focus also on tertiary care, and especially in India, government medical college hospitals, to improve the quality of universal health coverage. So I want about this.
Medical colleges, who wants to take the... Professor Mansoor, you like to comment? Yeah, okay.
Hello. In Thailand, we have referral system. Even we have USC, Universal Health Coverage. That means they have to go to the hospital that is registered in the card. And then if this kind of disease is needed for tertiary care, they use those kind of referral system to the medical college. We have exceptions such as if this kind of is very emergency or maybe urgency condition, they can enroll any kind of hospital anywhere. So that is also, we try to keep the medical college to have quite, not focus on only the primary care. They focus on the secondary and tertiary care.
Thank you very much. I think we have the next session. I think the speakers and chair already here. So I'd like to take this opportunity to thank all the speakers for their excellent presentations and also for the participants for interactive session. Thank you very much.
Thank you, sir. I request all the speakers to kindly stay on the stage for felicitation. I request Dr. Madhu Gupta to kindly come over the stage to felicitate Dr. Janki from Sri Lanka. I request Dr. Neetu Sharma to kindly come over the stage to felicitate Dr. Thalatha from Sri Lanka. Dr. Thalatha from Sri Lanka. I invite Mrs. Ritu Gupta to kindly come on the stage to felicitate Dr. Annapurna Sen. Dr. Annapurna Sen, kindly come over the stage. Please, ma'am. I request Dr. Ashok Sharma, Director Medical Education, to kindly come over the stage to felicitate Dr. James Kingland. Next, I request Dr. Pradeep Khanna to kindly come over the stage to felicitate Dr. Mansoor Ahmed. I request Dr. G.S. Thakur to kindly come over the stage to felicitate Dr. Suryodot Tripathi. May I request Dr. Rajesh Kumar to kindly come over the stage to felicitate Dr. Ajay Vatsayan. Dr. Rajesh Kumar.
And say hello to you. Yeah, unfortunately, I didn't remember. Yeah, I will write it down. No, I will see how I can. Because I retired from WHO, I often not try to stay away, you know.
I request Dr. I request Dr. Akshay Minhas to kindly felicitate Dr. Rajesh Guleria. May I now request Dr. Brit Sharma to kindly come over the stage to felicitate Dr. J.P. Narayan.
Oh, for me.
सबको होगा ना जिन्होंने फेलिसिटेट किया या लिया सबको पूरा बड़ा ग्रुप ये बड़ा ग्रुप हो गया ना चलो बड़ी पल्ले चलो चलो यहाँ भी दोनों हमने ही सेट कर दिए आगे 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 चलो सर ये कॉन्फ्रेंस का सूत्रधार है सूत्रधार
मेरी प्रेजेंटेशन अभी डेट मुझे करना रहेगी
कौन बचा बस ये आपको आगे करना पड़ता
I request all the dignitaries to kindly come ahead for a group photograph.
Yeah, I can hold this.